Good morning, everyone. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy, and I'd like to welcome all of you here with us at Duke and all of you joining us online for this morning's Point of Care event. This is the third seminar in our new series, and also want to welcome you on behalf of our colleagues at Blue Cross Blue Shield of North Carolina, who along with Duke-Margolis are supporting this seminar series to bring innovative thought leaders in health policy and health reform to Duke, Durham, and the larger health policy community around the country. I am very pleased to have with us today Dr. Lena Wen, who is going to talk about her experiences as a physician and a public health advocate and leader to talk about how we can work together to advance health and equity in our communities and throughout our nation. Dr. Wen has a unique background to talk about these issues. She's lived them. She is an emergency physician and visiting professor of health policy and management at the George Washington Milken Institute School of Public Health now. Previously, she served as president of Planned Parenthood Federation of America and also as the health commissioner for Baltimore City. She came by this commitment to public service and public health from a whole series of life experiences. She was born in Shanghai and was a Rhodes Scholar at Oxford, a reporter with New York Times' Nick Kristof, a fellow at the World Health Organization, and the director of patient-centered care research in the Department of Emergency Medicine at George Washington University. She was inspired to these activities and I think growing up as well through a long illness of her mother, and she authored a book, When Doctors Don't Listen, that is about empowering patients to avoid misdiagnoses and unnecessary tests. And that same spirit of trying to get health care and the non-medical services that have such a difference on population health right and focused on what patients really need has been a hallmark of her career and a passion throughout her life. She served as president of the American Medical Student Association, chair of the International Young Professionals Commission. She also helped create Who's My Doctor, a campaign for real transparency in medicine. And we're very pleased to have her with us today to provide some perspectives based on all those experiences. And then after her remarks, we're going to talk together a little bit, fireside chat up front, and have an opportunity to talk with all of you about what all this means for the future of health, public health, and equity in the United States. Lena, really pleased to have you with us this morning. Thank you. I should also say that I think this is one of Lena's last travel events before a certain big personal event coming up. Thanks again for being here.
Of course. Thank you very much, Mark. Well, good morning, everyone. Good morning. So, Mark, thank you very much for that kind introduction. One of the things that he did not mention was that I had the opportunity about now 15 years ago or so, maybe that dates us a bit too much, but I had the opportunity to work with Mark when I was finishing medical school. And so I had the opportunity to work for him when he was at the Brookings Institution, and really am ever in awe of his leadership. And so thank you for everything that you've done for our country. Thank you for what you're doing here at Duke, and also thank you for inviting me here. So thanks so much. If you can just join me in giving a round of applause to Dr. Mark McClellan. All right, and I also want to thank Dr. Karina Sorensen here at the Duke-Margolis Institute, and of course all of you I know that there is quite a wide representation of people from Duke and also from Blue Cross Blue Shield of North Carolina, and so thank you all for participating here today, and I look forward to our fireside chat and further discussion as well. I'm glad to be here in North Carolina. Your state is known for leading the way when it comes to major transformation in healthcare. And you're known for your work in emphasizing value-based care, innovative payment reform. Something else that I'll be addressing too is my work and interest in behavioral health, which is another area that you all have been leading in terms of integrating behavioral health into the rest of the understanding of physical health, that it cannot be separated from everything else. And of course, your work in addressing the social determinants of health too, through multiple collaborations, including your Healthy Opportunities pilot. But what I want to talk about today, I want to take you to my city, which is the city of Baltimore. And you'll notice, by the way, that I don't have any slides. You're welcome to give me feedback afterwards that I should have more slides, but I don't have any. I actually used to begin these presentations with a series of maps of my city. And I actually started getting feedback that I should stop doing that because it was essentially the same map. Because no matter what we had in the legend, whether the legend is of infant mortality, life expectancy, cardiovascular disease, rates of incarceration, addiction, overdose, whatever you can think of, it was essentially the same map, just different things that are entered in the legend. And in fact, that map itself was the map of the social determinants of health. A child born today in my city can expect to live in one neighborhood up to 85 years, or in another neighborhood just a few miles away, 65 years. A 20-year difference in life expectancy, which again illustrates how acutely it is that the currency of inequality is years of life. And that as we talk about choice, we also have to talk about privilege and how that choice is predicated on privilege and how public health has the opportunity to level the playing field of inequality. Now, the problem, though, is when we talk about these social determinants, and I think there's so often a tendency, this is why I stopped showing that map too, there is a tendency to focus on the problem, which I think we do need to describe the problem and illustrate the disparities, but sometimes we spend so much time admiring the problem and getting into if everything is related to something else, where do we begin, right? If health is related to education and income inequality, if all these things are related, where do we begin? And what can we each do from our vantage point? And so what I like to do is to give you three ideas, three themes of how we in Baltimore have addressed these issues, or are beginning to address these larger issues of social determinants. Some examples of what I've seen around the country, also fitting into these three themes. And then I'd love to hear your ideas and thoughts about that, especially as it applies here in North Carolina as well. So 3 themes. The first is to find what you can do, not just what you cannot do. And I want to give you the example of how we approach this, particularly around addiction in our city. So Baltimore, just like every major city and just like all across the country, when I was starting in my role back when I was first appointed in 2014 as the Commissioner of Health, we were facing an escalation of the opioid epidemic. And in particular, fentanyl was becoming a major problem, with the number of people dying from fentanyl overdose escalating from the single digits to the triple digits within a matter of a couple of years. Now, ultimately, we know that addiction is a disease, that we need treatment, and that treatment on demand, which is what we would expect for any ailment, is nowhere near that for the disease of addiction. Surgeon General's report found that only 1 in 10 people with the disease of addiction are getting the help that they need, which, as an emergency physician, I think about this frequently because I'll have patients coming to the ER and I'll have to tell them, I'm sorry, I can't get you treatment today. Come back in 2 or 3 weeks and maybe I can find you treatment then. And I just wonder, for what other illness would we ever say that? Would we have a patient who's coming in with chest pain and we tell them, oh, you have a heart attack, come back in 3 weeks if you're not dead by then? We just would never find that to be acceptable, and yet we do that for addiction. And I think, one of the things that really broke my heart was how frequently my patients who know that they need help for addiction would come in, ask for help. We all know that this patient needs help, but we just can't get them the treatment that they need. And often our patients would learn to lie to us and say that they're suicidal, because they know that if they say that, at least it'll buy them a few more hours of evaluation in the ED. I mean, that's what kind of reflection of our healthcare system is it when our patients are lying to us in order to get the care that they actually need? So coming into Baltimore, I knew that getting treatment was ultimately what we needed in order to turn the tide. The problem was that just like around the country, and I suspect here as well, we face the issue of NIMBY, the not in my backyard. That even as people recognize that individuals with addiction are our family members, our friends, they don't want addiction treatment centers where they are. It was so bad in Baltimore that one of our community leaders coined it not only the NIMBY issue, but the banana issue, which is don't build anything near anything that's near anything. And there were all kinds of proposals for the banana. The people were saying, well, here are all these abandoned industrial sites. Why don't you build methadone clinics and treatment centers there? Well, there's a reason why they're abandoned industrial sites. Nobody goes there. There are no bus routes. I mean, it didn't make sense that, again, nobody says, oh, I don't want a state-of-the-art cancer treatment center in my hospital. Right? Nobody says that. And so why do we treat addiction differently? I mention all of this because in this landscape where there is such huge stigma and misconception around addiction, starting with treatment would have been a very difficult proposition for us, which is why, and along the theme of find what you can do, not what you can't, what we did was to start with overdose prevention. Working in the ER, I've seen many patients come through who are overdosing, and I know that naloxone, or Narcan, the antidote, can immediately reverse their overdose. And we thought, this is something that we can do right now that can galvanize public interest and attention and show people that there's something very simple you can do, and also that these are your family members, friends, neighbors. These are not random people. And it becomes much harder to argue that if somebody is dying in front of you right now, that you shouldn't save their life. So what we did was in 2015, we got legislation passed to the state that enabled me to issue a standing order, which is the blanket prescription for naloxone, to every single one of our 620,000 residents. Which at that time, I mean now it's commonplace, but at that time, I will say that it was a little bit scary to write my signature and NPI number on 620,000 prescriptions. We knew that just changing policy alone was not enough, that we also had to have services that went with it as well. And so on the day that the standing order went into effect, we also had already trained dozens of community groups for Train the Trainer, so they were ready to go. And we send outreach teams every single day. We did hotspotting to figure out where were the areas hardest hit by overdose. We sent out teams to wherever it is that people were, whether it was street corners or bus shelters or bars and restaurants or just people out in mobile vans to teach about naloxone and to also get people into treatment at that time too. And as a result of our outreach and as a result of the standing order, everyday residents used naloxone to save nearly 3,000 lives within 3 years. Now, I mention this because that type of short-term action, even though this is not the final answer, right? I mean, getting somebody to be reversed from overdose, it just means that they're alive right now. But that was key to galvanizing the attention that we needed in order to implement long-term change when it came to increasing access to treatment. And so over those 3 years, while our naloxone work was in progress, we also started a stabilization center, which is the first of its kind treatment center that's a pre-hospital diversion from the ED in order for people to get treatment. So patients would otherwise go to the ED for addiction and need mental health and social services. Instead, they would be diverted to the stabilization center where they would be seen by someone who is equipped to handle what they need, which, by the way, working in the ED was something that I always wished for because I knew that I was not providing the ideal care that these patients needed. This was something that's a beginning of treatment on demand, and patients could get buprenorphine induction from the stabilization center and so forth. We also took a page from the work that's being done in Rhode Island to start levels of care certification. So just as hospitals are certified for trauma, level 1, level 2, level 3, we also worked with all of our 11 acute care hospitals in Baltimore to start levels of care certification for addiction and mental health support too. I give these examples because so often we wait for the perfect solution. Another example of this too is, with fentanyl, there were all these task forces that were being convened by federal agencies, by state agencies, locally, and I think everybody was waiting for, there were just all these legal issues that we had to go through for data sharing and medical record sharing, and it was taking a long time, frankly. And it was also, there was no end in sight. I mean, people wanted to develop these great dashboards and great apps, which I agree are wonderful if we could get them off the ground. But in the meantime, people were dying. And we wanted to do something fairly quickly. And one of my assistants came up with a system that was as basic and low-tech as you could get, which involved an Excel spreadsheet and a phone. And basically, we said anytime that there are overdoses occurring, a cluster of overdoses occurring, we wanted for people to just call his phone, like his actual cell phone. And so we would have hospitals or EMS or community groups saying, look, we just had a cluster of overdoses occurring. I don't know this is fentanyl, right? Because we don't know that it's fentanyl until somebody gets tested for it, and that may take days or weeks for those results to come back. But if we know that this cluster is occurring, we can send outreach teams to that neighborhood to educate about fentanyl, to get naloxone into the hands of people. And I just give this example of how we cannot wait for perfect to be the enemy of the good. And that's the first theme of finding what you can do now and not what you can't. All right, so I want to go to a second theme, which is to focus on our children, to start with our children. So back in 2009, Baltimore had one of the worst infant mortality rates in the country. The disparities also were profound. An African-American baby born was 5 times more likely to die in their first year of life than a white baby in 2009. So the health department in Baltimore, along with a number of community partners, convened eventually over 150 public and private partners. All of our hospitals, our insurers, and also our faith groups and nonprofits and a number of other groups that were doing their own outreach efforts, but we combined them into one collective action plan called Be More for Healthy Babies. And that included a number of efforts, including triaging every pregnant woman on Medicaid into different levels of care. So somebody with physical health issues, behavioral health issues may be triaged to the highest level of care and receive a nurse home visitor. Somebody else may have a social worker, somebody else may have a community health worker, etc. This was also combined with teaching the ABCs of safe sleep, lactation support, a number of other support services for new parents, free cribs, other services, etc. And this program, I'll describe to you that eventually it was very successful, although not always was it successful. And I'll give you an example of what we found. Co-sleeping, as you know, is a major risk factor for SIDS and also for infant mortality in the first year. And so we had we started this program for free cribs, thinking that it would decrease the rate of co-sleeping, but it didn't, and we wanted to know why. And then our nurse home visitors went to visit and found that the babies were still sleeping in unsafe sleep environments. They were co-sleeping, they were sleeping on a couch. I mean, there was maybe a crib, but it had 5,000 stuffed animals in them. We thought that it was mainly an educational issue, and then so began doing education on the need for the ABCs of safe sleep, the alone, on the back, in a crib, etc. But then we found that there was another issue, because the nurse home visitors, when they went to visit these homes, found that when the free crib was delivered, it remained in a flat pack, unopened. And that there was a major barrier, but one that was surmountable, which is to have someone, when they deliver the crib, to also make the crib too. I mean, this is a minor example, but I use this because so many times we go into something with a plan. And that plan is based on evidence and is good strategy, but we also have to be willing to evaluate and course correct frequently, depending on what else may happen. And so we had set this North Star and said, here's a strategy that's based on evidence. But so many times, I think the cribs are a good example of this. Another may be that when we taught the ABCs of safe sleep, we recognized that this was not just a one-time education to one group, that teaching the ABCs of safe sleep had to be reiterated over and over again to providers, to patients, through trusted messengers in the community, and that kind of iterative process was really key. Well, as a result of all of these interventions by all of these various public and private partners, we reduced the infant mortality in our city by 38% in 7 years. And when I think about what this means, I mean, I have a 2-year-old, and you see that I'm 7 months pregnant, and so expecting my second, hopefully in 2 months. When I think about what this means, it means that 50 babies that would have died in 2009 are able to be alive today. And by the way, we also closed the disparity between Black and white infant mortality in our city by over 50% in that same time period. And so this is an example, I think, of why it's important to focus on our children, and also that there is a way for us to both improve health and close disparities, aiming for equity at the same time. Now, I do want to take a slight diversion on the second theme about focusing on children, because we got a fair amount of criticism for both of the types of programs that we had around healthy babies and also around our addiction work, because people would say, well, this is what you're doing now to help these patients, whether it's babies and families or people with addiction. But what are you doing to address the root cause of the problem? And to be sure, there are a lot of root causes. I mean, and I understand where this criticism is coming from. I'm sure all of you have heard or all of you know about the Upstream Model. And I really like the concept, the upstream parable that's often told, that there are 3 friends. Have you all heard about this? The 3 friends walking along the river? Okay, so some of you haven't, some of you haven't. So the parable goes that there are 3 friends who are walking along, and there's a stream with a very quickly moving tide. And they begin to see that there are children floating by who are drowning in this tide. And the first person goes in to save these children, but is only able to save a few. There's still more children going by. The second person runs upstream and sees that there's a dam and tries to fix the dam. Then the third person keeps on running upstream, and the first 2 call after him, why are you running? You know, there are children here. And this person says, well, I'm trying to see who's throwing in these children in the first place. And I really get that. I really get the concept of going upstream and finding out what are these root causes. We know that when it comes to addiction, that so much of what fuel these diseases of despair are hopelessness and homelessness and lack of economic opportunity. And there are so many other issues, societal issues, that must be addressed too. But I would also argue that our role in public health, as insurers, as providers, et cetera, it also has to be aiming for midstream and upstream interventions too. That certainly my role as an emergency physician, if somebody is dying in front of me right now, not only is it irresponsible, but it's also immoral for me not to save their life now. Well, it doesn't mean that we don't also aim for these long-term actions and the long-term structural reforms that are important. But if somebody's dying right now from overdose, we have to save their life right now, or else there's no chance for a better tomorrow. With our babies and infant mortality, yes, there is a lot to do, a lot more to do. And maybe this is not the solution that we need overall in society, but if we can save 50 babies every year due to our interventions, how can we not do that? You know, we had also implemented a program in our city that I'm very proud of. That's a very simple intervention of getting glasses to every child who needs them. Because there was a study done that found that up to 10,000 children, school-age children, needed glasses but were not getting them. And so we started a program, Vision for Baltimore, to get glasses to every child. I mean, I'm all for research, and I know I'm in an academic institution now as I say this, but I don't need another study to tell me that if kids can't see, they can't read, and may be labeled as being disruptive or being put back further at school. And so if there's something, I know that glasses themselves are not the answer to education reform, but if that's one thing that we can do to make a difference in someone's life, shouldn't we also start there too? So I'm getting a bit more controversial, I think, as we go along with this theme. But find out what you can do, what you can't do. Focus on our children, and I would say, don't forget midstream and downstream interventions. And then I'll give you a third theme as well. And that third theme is we should stop the siloing of healthcare. Specifically, what I mean is, we talked about addiction, and addiction and mental health, I think you all know, is often and unfortunately seen as something separate from the standard healthcare that it is. That there is huge stigma and misconception that's reflected in the delivery of the services, in reimbursement, in our culture, that addiction has so long been portrayed as a moral failing, instead of as the disease that it is. And frankly, it's been portrayed as a moral failing primarily when it was something that affected poor communities in urban cities. And I do think it needs to be said that there is a racial component involved, that now that addiction is seen to affect white communities in rural, suburban areas, that it's called a disease. And I know this is something that comes up in my city a lot, a city that's majority minority, that there were people dying from the opioid epidemic back in the 80s and 90s, but we've incarcerated generations of Black and brown people instead of getting them the treatment that they need. So why is this suddenly changing? No doubt, addiction and mental health, there's still a long way for us to go, although there is growing recognition that they need to be treated as the disease that they are. I would say, too, that women's health, especially women's reproductive health, is also seen to be separate from the standard healthcare that they are. Even the fact that we're discussing this, we don't have conversations about how men's health should be treated as standard healthcare. It just is standard healthcare. So why don't we also treat women's healthcare in that same breath? I believe that there is a way for us to depoliticize the issues, all of these issues, addiction, mental health, reproductive healthcare, and treating them all as aspects of healthcare by focusing on points of agreement. For example, about women's healthcare. I think there is fairly broad agreement that maternal mortality is a major issue. I think about this a lot right now, but just, the fact that women today are more likely to die in pregnancy than our mothers were. How is that? How is that possible? Or that an African-American woman is 3 to 4 times more likely to die due to pregnancy-related causes than white women today. I think most of us can agree that prevention is the best medicine when it comes to all aspects of healthcare, including with reproductive healthcare. And I think importantly, too, that every interaction ideally should be a point of intervention, meaning that people who are in primary care should not only be seeing what are traditionally seen as primary care issues, but also that reproductive health care and mental health and behavioral health more broadly should be incorporated into that too. And by the same token, that reproductive health providers, many of whom, for whom many patients may only see that one provider as their source of health care, if that's the case, they also have a responsibility to not only be providing birth control and testing for STDs, but they also have a responsibility to screen for chronic conditions and mental health issues as well. And I think the more we can do that, the more that reflects what we know in medicine to be true, which is that the best care we can provide is whole person care. That the more that we can also reflect that in the services we provide, it also takes all of these issues that are previously seen as being siloed out of the political sphere and into the medical sphere where they actually belong. So I would love to hear more about your reactions to all 3 of these themes. I wanted to end today, this portion, by giving you a quote that one of my heroes and mentors, the late Congressman Elijah Cummings, used to say. As you know, he passed away a few months ago, and I feel like I'm channeling him every time I say this. But he often would talk about the work that we have in front of us as being bigger than us. It's being much bigger than us. That ultimately it's about our children, who are messengers to a future that we will never see. And ultimately, that's why we do the work that we do. That it's not the policies and talking points and the strategies of what we're fighting about, but ultimately it's about who we're fighting for. So I thank you for your tremendous work. Together, I believe that we can take action now, focusing on what we can do to treat the whole person and stop siloing of the specific aspects of healthcare. And so thank you for joining us all together on this journey to improve health and advance equity, always in service to our patients and the communities that we serve. Thank you.
Thank you. Great. Thanks very much, Lena. We're now going to move into the fireside chat part of this discussion, which is going to be pretty challenging to follow with all of those inspirational comments. And plus the nice comments about me. I appreciate that too.
Or if we can.
No, let's go on to back to the inspirational part. But as you mentioned, this is a state here in North Carolina where healthcare reform is front and center, and maybe a bit different than some others. It's really a purple state, a Democratic governor, Republican legislature, and while there is a real commitment on both sides to transformational reform, as reflected in the Medicaid reform efforts, as reflected in things that are happening across health systems and moving to ACOs and other steps, a lot of commitment for action. On the other hand, the politics is there. There's a budget standoff going on right now that's holding up the implementation of some of these reforms due to some understandable differences in political views about the importance of Medicaid expansion. People just have different views on that, and the state has not expanded Medicaid. So I'm wondering if you can offer some advice on helping this state continue to move forward. I would say, just as you emphasized maternal health and infant mortality, talking to many leaders around the state here and people around the state, I mean, that really resonates. We've seen increased maternal mortality rates in North Carolina, big disparities in birth outcomes, and a lot of interest in trying to take some more steps there. So I'm wondering if you can give us a few more thoughts about kind of applying your principles of starting somewhere and building out progress despite these important these important underlying political differences.
It's such a great question, and I think that so much of the work that you've done in your career and also the great work that's done in North Carolina reflects the principles that I think we all share in this room, which is that ultimately it's about the people that we serve. One of my concerns about today's political situation, and this is, by the way, not at all a partisan comment, this is just my overall reflection, is that the temperature is so high and everything, it feels like there are just people shouting at each other. And maybe that's the reality of I just spent a lot of time this morning watching the impeachment hearings, and so maybe this is reflected in part by that. But I also think that so often there are discussions about ideological differences, and we get stuck there rather than on what we have in common. And what are the steps that we can move together on that the American people really want? I mean, I think that the vast majority of the American people actually want similar things. How we get there how we get there specifically may be different, but I think ultimately we have a lot of shared values. And so I think for for me as a physician, I think certainly now that I've returned back to academia and back to a less politicized place, I think there are things that we can do that make incremental progress, which, by the way, I do not think is a bad thing. There's a lot of discussion now about how we need total change. And I may not agree, or I may agree. I don't think it even matters whether we agree on the fact that we need total structural change. I think what matters is, can we make incremental progress that does make a big difference for the people in front of us? One of the things in Baltimore that I'm particularly proud of is those things that maybe in the long term are not seen as huge changes. But I remember about the glasses program, we had a reporter from PBS NewsHour, I think it was, come and do a profile of our glasses program. And I think they came at the time that these kids were getting glasses for the first time, and we partnered with Warby Parker so that they could select their own frames and their own colors.
Some pretty nice frames for those kids.
Exactly, they could choose their own colors, and I think the reporters were hoping for this aha moment that the kid puts on the new frames and is like, "This is amazing, I can see." I think they were looking for that. So there was this 8-year-old girl who was just getting her pink frames, and she was reading. The reporter asked her to read some text first without her glasses. And she read, and it was a bit halting and slow, and she stopped in certain places and squinted. And then the reporter asked her to put on the glasses, and she did. And she read much faster this time and fluently. So the reporter said, cameras on, said, "Did you see a difference?" She said, "No." I was like, "Are you sure you don't see a difference?" And she was really unimpressed. She was like, "No." But what was interesting was that right off the camera, there was a school aide who had been working for our health department for over 20 years. She had tears streaming down her face, because she could see the difference that something as basic as a pair of glasses could make on the trajectory of this girl's life. And to me, that's why we do the work that we do. That's why incrementalism, even though sometimes it's being said as not enough, sure, it may not be enough. But if there's something tangible we can do to make a difference in someone's life, we should do that too.
I want to come back to these big political, philosophical differences, but first, just to pick up on another theme from your remarks that, again, I want to push on relevance here in North Carolina. So this is a state where at Blue Cross and other private insurance plans in the state government, led by Secretary Cohen, implementing Medicaid reforms, and again, building on some Medicare programs, is really committed to changing the way that we pay in healthcare with systems like Duke and UNC and many others, and many of the smaller healthcare providers in the state have all signed contracts that say over the next few years we're going to move away from fee-for-service, we're going to pay on more of a person basis, with the goal of supporting the kinds of reforms that you've mentioned that, for like a lot of the reasons that you've said, are kind of difficult to do in traditional fee-for-service. But I'd say, based on my experience with a lot of these payment reforms, it's sort of like you said with the other interventions. It's when you actually change the policy, big or small, that is just the first step, and by itself tends to not succeed. So there are lots of organizations around the state, around the country, that have implemented payment reforms with the same goal as what you said, of taking some other step to improve health outcomes, and it doesn't quite work out as intended. I want to go back to your comment about it's not just changing, in effect, it's not just changing the policy, but sticking with it, having to engage with how reforms or ideas for reforms actually play out in the community, and being willing to adjust as you go along. That does seem like a general phenomenon in trying to reform healthcare, even steps that may seem small. What have you learned about how to keep the the commitment and the energy through that. I mean, it does seem like these, having small steps that have the visible, literally visual impact, like you were just describing, can help. But it's a tough journey when many people are angry and are looking for faster, bigger, easier change.
Yeah, I mean, it's such a good point. I do think that we have to combine our long-term goals with short-term tangible solutions. In public health and population health, so many of our metrics are really long-term, right? I mean, increasing life expectancy or decreasing cardiovascular disease. I mean, the trajectory is so long that we lose people along the way. And I know working in Baltimore that there is this sense in our community that they've been made many promises and they want to see tangible things being done. And so for all of our strategies, we combined our long-term goal. We might set a long-term goal of reducing cardiovascular disease by X amount by a certain time, but short-term steps involve the things that our residents themselves help to come up with. One of the issues that was identified as an example was food deserts. The fact that 1 in 3 African Americans in Baltimore live in a food desert compared to 1 in 12 whites. And I always felt hypocritical telling my patients that they should eat healthier if they then tell me I have to take 2 buses and then walk 10 blocks. And then, by the way, it's a Whole Foods that I'm going to and it's really expensive. I mean, I don't feel that I'm giving them really good advice about eating healthier if that healthy food isn't accessible. So we also started partnerships to deliver food to people where they are. We had partnerships to make corner stores, healthy stores, to help make the corner stores to be healthy corner stores and provide fresh food and vegetable options. I mean, these are things that by themselves probably are not going to move the needle on health outcomes, but they were small, short-term, very tangible, very visible outcomes that then allowed for there to continue to be momentum, and I think critically trust in the outcome too. I think another component too is that we have to remain flexible and be open to the perception of failure. And I think so often in government, there isn't that tolerance of failure, when actually failure is key to innovation. And I think I had heard someone say, and I don't think I'm using the exact quote here, but that we should be firm on our principles, but flexible on our preferences. And I like that way of thinking about the work that we do more broadly too, that we shouldn't be sacrificing progress at the pillar of ideology, and also that we need to be ready to course adjust, that we come in here with a North Star, and the North Star should always be serving patients and populations and communities. But how we do that may change depending on shifting circumstances, shifting politics, and frankly, what we're finding out to be effective or ineffective strategies. And that's not failure, that's just common sense.
Yeah, and so this, some attention to short-term achievable steps and fostering an environment for reforms where failures or modifications are not only okay, but they're expected, and that's how you make the programs better, seems like a really effective strategy. I do want to, since you said you didn't mind being provocative, I want to go back and connect that to the bigger debates, pretty fundamental debates we're having right now in this presidential election year about the future of healthcare and health systems in this country. So Representative Cummings was a very visible and passionate leader on a range of these issues, including issues like Medicare for all, a universal government-run kind of single-payer health system. So can I ask you about what do you think about that kind of proposal?
I had written an op-ed in the Washington Post that was titled, "Can we please stop talking about Medicare for all?" And once I wrote that, I had people labeling me as a moderate scold, which frankly is a title.
You took that as a compliment?
I embrace it, because I think a lot of times I think people who have more centrist views get accused of compromising their values, when in fact, again, to cite Congressman Cummings, he said that we should not only be aiming for common ground, we should be aiming for higher ground. I think there often is another solution that we're not looking at. And it doesn't mean that we have to be compromising to find exactly what is the middle, although sometimes that's necessary. Sometimes we need to look for something else that may get to the point of where we need to be. And my concern with Medicare for All, and I had written this after a number of Democratic debates where it felt like the entire conversation around healthcare centered on Medicare for All. And as you know, Medicare for All is one way of paying for healthcare. It's such a limited perspective of what we need in our healthcare system. I mean, if the conversation is dominated by this very specific proposal of how to pay for healthcare, we're not addressing so many other aspects. We're not addressing access to care, quality of care. I think that so often too, people, and not a crowd like this, but I think a lot of audiences misinterpret Medicare for All as, or they conflate Medicare for All as universal health care. And I think that's an important distinction. I mean, I think there are a lot of people who believe in the idea that healthcare needs to be a human right, that it needs to be affordable and available to all people, that people should not be priced out of the ability to pay, that you shouldn't have to go bankrupt because you get cancer. I mean, I think a lot of people agree with that principle. But as to how exactly you get there, there are many paths there, of which Medicare for All is one, but certainly not the only one. And so I just think that there needs to be a broader conversation around healthcare, that this fixation on Medicare for All actually takes us away from the core issues, and then we end up fighting about a policy when in fact we need to be talking about the core principles of why we're here. And I think critically, so much of what's left out of the Medicare for All conversation is the topic of prevention. I mean, I would love for
and some of the public health initiatives that you were just describing.
That's right, and a lot of the work that you're doing here in the state around social determinants and population health. I mean, I would love for, one of the candidates to stand up and say, let's not talk about Medicare for All. How about let's talk about keeping our children healthy and preventing them from getting lead poison in the first place, about the health, about the air that we breathe and the transportation that we have access to, and how that also ties into health as well. I mean, I think there's a much broader conversation that actually determines the quality and length of someone's life that's not fixated on a single policy.
Let me ask you one more maybe hard question along the same line. So you have clearly been living this approach of having those big goals like you were just describing, but definitely recognizing that there are many paths to get there, and that having a more holistic approach to health can be accomplished through incremental practical steps, even if we have these big philosophical debates, and important philosophical debates, don't get me wrong, even if those aren't getting resolved. So you lived through what must have been a challenging experience at Planned Parenthood, where I can see you taking exactly these approaches in to a setting where the reproductive health issues, those are right up at the top of the list of political and philosophical divisions. You lived through that. You still seem to have faith in the approach of trying to build out consensus and practical progress. Any lessons from that people here who also want to make a difference and maybe care about some of these political issues a lot, but still want to get things done at the same time? How do you reconcile all of that in a very challenging political environment?
Oh, that's a great question, and thank you for the very tactful way that you're asking it. I mean, I do want to, and I'm glad that you gave me the opportunity to address this, because I do think it's important to talk about my experience at Planned Parenthood. As you know, I left my job at the Baltimore City Health Department, which was really a dream job to be able to make this kind of impact on the city, for Planned Parenthood. And I had done that because I wanted to depoliticize something that I thought was, that again, the temperature had been turned up so high on something that I understand to be a medical issue. I mean, I came to this work, I was born after Roe versus Wade, but I had professors and attendings who told me about what life was like pre-Roe, that there were entire areas of the hospital in the sepsis ward where there were women who were dying from kidney infections and sepsis and organ failure and all these things because they didn't have access to safe legal abortion care. that worldwide 70,000 women die because of this, because of illegal abortions. And I understand abortion care, reproductive health care to be part of healthcare, and that's what I wanted to do at Planned Parenthood, to take it out of the political sphere, to talk about all of these issues as healthcare issues. And because Planned Parenthood has over 600 health centers around the country, and many patients for whom this is their only source of healthcare, I also wanted to expand that care, expand to more areas, and critically expand services. Because this is along the lines of what I was discussing for theme number 3, that I believe every interaction should be a point of intervention. And so if somebody only sees a reproductive health provider, nobody just has tattooed on their head, birth control, right? I mean, people who come in requesting birth control may also have undiagnosed high blood pressure, untreated depression, and this is also an opportunity to do that. And so I went into Planned Parenthood with that mindset of trying to depoliticize healthcare and reproductive healthcare specifically, and looking to expand access to care to wider populations and comprehensive care. Now, you all know that I left Planned Parenthood last July because of disagreements about this philosophy. And I do think that, to your point, Mark, about what I've learned, I do think it's important to acknowledge that good people who have similar values and similar goals can disagree on strategy. There is another point of view, which I'm going to state. I may not agree with it, but look, who am I to say that my point of view is the right view? If I knew that this was the right thing to do, we wouldn't be having all these disagreements in the country. We don't know our own counterfactual. I think there's another point of view that reproductive rights are under attack like never before. That Roe versus Wade is going to be reevaluated by the Supreme Court potentially in March, and we don't know what's going to happen, especially with the rhetoric that's coming out of this administration. Again, not a partisan statement, just saying that's literally what's being said. And so I think another point of view is that in these times, it's important to double down on abortion rights, to specifically double down on the base with 2020 already here. Now, I think it is a significantly different point of view from the depoliticizing, turning down the temperature, right, versus turning up the temperature and rallying the base. I think both are possible. And my point of view remains that the more that we can be inclusive, the better. I've met many people who have complicated views about abortion, who may struggle with the morality of abortion, but who do not want the government to interfere with personal medical decisions, or who may have trouble with the idea of abortions later in pregnancy, but would not want these restrictions as they are being passed in Alabama and other places that even forbid abortions in the case of rape or incest. I think there are a lot of nuanced views that Americans have about this issue. But I also think that the more that we can frame them in terms of healthcare, the more that we talk about the points of agreement that we have, rather than emphasizing the differences, that's how we can really make progress as a country. But that said, good people can disagree on strategy. And I do hope that at the end of the day, that's what we focus on, about what we have in common, rather than what separates us.
And looking ahead, despite all of the challenges that you've had to deal with, being on the front lines of trying to take this practical approach to some issues that very closely intersect with deep and, again, understandable political controversies, any recommendations for, what do you call it, moderate scolds heading into 2020 and 2021? I actually don't think that does it justice. I would say, I get your point about what you meant by moderate, but I think your goals and aspirations and practical strategic steps to get there are by no means, they're bold around addressing disparities and staying with these really hard issues despite the political complications. Any advice for people out there who have kind of identify with the strategic approach you're taking?
Until this year, maybe not this year, this is 2020, so we've only been in this year for a few days. Until last year, I don't know that I would have identified myself as a moderate or a moderate scold. I actually thought of myself as a progressive in the work that we did in Baltimore. I mean, we called out racism as a public health issue. Right? We were addressing gun violence as a public health issue years ago. We were one of the first cities within 25 years ago to start needle exchange. And this is the environment that I walked into and was home. And
That's what I mean by bold,
I don't know that I would have considered myself, right, to be anything other than a progressive. But I think that in today's environment, again, I don't know that I've changed my views and my values, but I think that so much of this country has moved in different directions. And there are all kinds of reasons for this, including social media. I mean, so many reasons for why it appears that the radical left and right are dominating the conversation. But I think that makes those of us who are practical progressives or practical moderates, or however we want to define ourselves, but those of us who are willing to make compromise, those of us who are willing to get small things done on the way to reaching a broader goal, that's why our work is more important than ever. You know, I've had to wrestle a lot in this last year, and in general, with how my voice can be the strongest. And you know, and this is an ongoing thought that I have. This is an ongoing conversation. But my sense is that, and Mark, you and I were talking about this a bit earlier. Again, the temperature is so high. I think that when people from different sides are saying things like, "This is the worst thing that's ever happened," or "This is the most outrageous thing," you can't say that all the time. And if you do, it cancels. Both sides end up canceling each other out. And so I actually think that there is a real need for voices like those of us in the room, whose principles are firmly grounded in what we see, in the work that we do every single day, in the patient care that we deliver, in the populations that we serve, in what we see and the stories that we hear. I think that is actually what will break through at this very divisive time. And no matter how we define ourselves politically, as long as we keep to our own North Star and speak with that authentic voice, I think that's what will break through and make a difference at the end of the day.
Thank you. So we have a little bit of time for questions from those of you who are here. Maybe we could raise the lights a little bit and see if there are any. Please just, and we've got microphones too, so just raise hands. I think, let's see, a couple over here. Yep.
Hi, Dr. Wynn. I really enjoyed your speech. I'm with LabCorp. I'm Pam Williams. I read this week, and I thought it was real interesting, and you kind of talked about schools and the glasses situation, about telehealth maybe coming to public schools. I don't know if that was in North Carolina. I read it in an article, but I thought, what a way to expand health care when the kids are there and the teachers are with them so much of the time, and I just wanted your thoughts on that.
I think it's a great idea. So it's about telehealth in schools. There's a neighboring county to ours in Baltimore City, Howard County, that piloted telemedicine back in the early 2010s, so about 10 years ago. And their program, I thought, was a great model. You can't have every health suite in schools be staffed by a physician or a physician assistant or a nurse practitioner, but they are staffed by a nurse aide and sometimes a nurse. And so what they did was set up consoles in these health suites where a nurse aide can facilitate the conversation with a physician and physician assistant, et cetera. They can put the stethoscope right on the patient that then on the other side they can listen to the person, they can look at the throat and look at strep throat. They can do actually quite a lot in terms of basic types of primary care and urgent care. And that not only is better care, it also allows the student to miss class less, for the caregiver, the parent to not miss work. And it's also a way to bring specialty types of services that would otherwise be inaccessible into these schools. And so when I was in Baltimore, we started to pilot this as well, specifically around mental health. Understanding that child psychiatry is something that's always a deficit in a lot of places. We started to pilot mental health care in our schools through telemedicine. And I think it's another important intervention of meeting people where they are, particularly to help those who are the most vulnerable.
Okay, someone over here too. Oh, okay. Wait for the microphone, sorry.
Is Blue Cross looking at something like this where they would be doing some type of telehealth into?
Well, I don't want to speak for Blue Cross, but looking around the room, I'd say I think Blue Cross has put maternal and child health high on the priority list, and just as a corollary, something I do know more directly about, North Carolina was just awarded a grant from CMS for the Integrated Care for Kids program, which is really about finding ways to do more integrated social, community, education, and medical services together with, for the reasons exactly like you said. Now, there's some practical issues here on the financing side, so there's some things you can do with Medicaid funds or some things you can do with school funds, and you need to find ways to braid and bring those streams together. But I think there's a lot of interest here on the private health plan side, on the public, the government side, and healthcare providers and schools to find ways to do this. And just like everything else we've talked about today, it's a great goal, but finding the practical steps to get there and doing the course corrections is going to be really critical too.
Hi there, Alicia Stokes. I'm the Director of Insights and Innovation at Blue Cross. And I had a question. In some of the earlier examples when you talked about the opioid crisis and how you all handled it in Baltimore, you talked about sending out teams to educate and then to help get folks in treatment. Understanding that I would assume that trust is a big factor and a big element in being able to actually educate and also get folks in the door. How did you all address that issue of trust and being able to get folks to actually listen and to adhere to the education and the treatments?
Yeah, it's a wonderful question. There is a core principle, as you all know, in public health, is the idea of the trusted messenger. If I were to walk the streets of West Baltimore and say to people to put down their weapons and not shoot each other, I'd be laughed at, right? I mean, it just wouldn't, I am not the most credible messenger in this regard. But we hire people, as an example, for a program called Safe Streets. That's based on a violence prevention model started in Chicago, Cure Violence, where individuals most of whom are recently released from incarceration, are hired as outreach workers. And these are the individuals who walk the streets. They identify where conflicts are likely to occur. They then have these conversations, and they also they're recognized in their communities. Not so much, I don't think they would use the term trusted messengers, but they're recognized as leaders in the community. They also are people who have been there. They've been in incarceration. They've been, they can talk about their own experiences in such a credible way that I wouldn't be able to. I'll give you another example that is less expected perhaps. Because we would expect, right, that we hire people in the community who then do outreach around healthy babies, around lead poisoning prevention, who are people in the community, or people who are in addiction treatment themselves, who are the most credible messengers to the people that they encounter. When we first started doing the naloxone trainings, one of the groups that we needed to reach, but were having some trouble, was the police department. So the police commissioner was very much in support of having frontline officers be trained to administer naloxone to save people's lives, because they might be the first responders who come on scene. And he was very much in favor of it. But this was, as you remember, 2015, right after the riots that followed the death of Freddie Gray in Baltimore. And community police relations were not great, and and there's still many issues to be sorted out, but at that time there was very high tension around this. And I remember one of the first trainings that we did for the police department in the summer of 2015, just a couple months after the riots and civil unrest in Baltimore, where the police officers that I was training looked like I was asking them to dissect rats. I mean, just the idea of doing the lock zone was just, it was unfathomable to people. And I saw the looks on their faces and realized, wow, I am not the most credible messenger in this case. And even the police commissioner, who was many levels above them in this hierarchical structure, may not be the most credible messenger. But what happened was something that I actually had not really planned for, which was that in the first month of having frontline officers carrying the lock zone, 4 officers used it to save 4 lives. Those officers became the best evangelists to their police department, to their fellow officers. And by the time that I was doing this training again in the spring, just 6 months later, the officers were competing against each other to see who could save the most number of lives. I mean, we think that culture change takes such a long time, and sometimes it does, but this was one of the most remarkable things that I'd ever seen of how the culture change occurred within a span of a few months, all for the better good because of trusted messengers.
Great. I think we have time for one more.
Hi, Sam Cohen. I wanted to go back to something you had said when you were giving the talk portion, and you said, I didn't need another study. And I think something similar can be said for small-scale healthcare demonstrations in some ways. So in your case, in Baltimore, you had what turned out to be a pretty successful intervention here just with the cribs. And doing that, and now you know that you need someone to set it up as well. Based on the success you had in Baltimore, have you seen other cities or states or insurers reach out and say, yes, we're going to implement this same thing? And if not, what do you think it will take to get someone, for instance, Blue Cross Blue Shield of North Carolina, to be willing to pay for that sort of intervention?
It's a really good question, and here...
Well, you had one success, and boom, everybody didn't just adopt it?
There are other places that have looked to the work that we've done duplicated in different ways. I know that Colorado was attempting something. A number of other places have tried similar types of programs, but in a way that's tailored for their community. New York City now has a doula program that's also along these same lines of meeting people where they are in the community, et cetera. I would say that even in our city, even in Baltimore, with the demonstrated successes, funding that program is a challenge every year. And it's one of the hardest, it's one of the most emotionally taxing, I would say, parts of my previous job, which is knowing that this is working, having the results that show that it's working, demonstrated lives saved, demonstrated cost savings, but people don't want to pay for it. The city and state, we always ran into budget shortfalls. I think it's been said that public health saved your life today, you just don't know it, right? That there's no face of public health, and so people are not investing in it. That it just was always, we always wanted to talk about the cost of not doing something and not just the cost of that intervention, but it was very challenging to get people to pay for it because where those savings were realized was not always clear. It wasn't just that it would save insurers money. It was not just that it would save hospitals or the city or the state. And I think part of the issue around so many of the programs that I described too is that they might reimburse for specific components. For example, if a child were being treated for asthma in a school, they might reimburse for that treatment. And maybe that encounter, right, would be paid for. But as in the case of getting glasses, so much of the work that's necessary was in the care coordination of how do you identify these children who test positive and then need to get a permission slip signed in order to get their free glasses. But who's paying for that care manager? And if you can't pay for that part, the whole program falls apart. And I think that's what we had the biggest challenge. It wasn't so much the individual services, but how do you get people connected to the treatment in the first place? And I think if you have good ideas for how to approach these payment challenges, I'd love to hear them, because at the end of the day, that's such a missing piece. And I think there are so many ways to say no to something based on that missing component. And I do think we need to be talking about the cost of inaction and of not doing something too.
Yeah, well, I do want to thank you for, we talked in the discussion a bit about the importance or potential importance of payment reform and helping to support these efforts. It is not easy, but I want to thank you for your demonstration of ways to move these issues forward, and not easy, but it is saving lives, and these kinds of programs are expanding. I think these ideas are taking root here and other places as well. I wish it was quicker and easier, but it's great to see a demonstration of just how it is possible to keep the commitment despite setbacks along the way, bumps in the road. You've been really honest and forthright with us this morning, and I think I speak on behalf of everybody here and saying, Lena, thanks for joining us, and thanks for the inspiration to making more real progress on improving healthcare and public health. Thank you so much for joining us today.
Thank you.
And